All right. Well, my name is Glenn Pierce, and I'm going to be covering the basics of gene therapy today. So this is going to be more of a basic talk, although gene therapy winds up being so technical, I'm sure some of you at the end of this will not think this is a basic talk. A little later this week, I'll be giving a more technical talk on gene therapy, I think on Wednesday. But the goal of this is to really bring us all up to speed on what is occurring in the area of gene therapy for both hemophilia A and hemophilia B. My disclosures: I'm on the board of directors for the World Federation, a few other boards, and am a consultant for several of the companies that are in this space. So what are we going to cover today? Well, we'll cover the known knowns and the known unknowns, but we will not cover the unknown unknowns today because we don't know what they are. And I'm going to go into a little more detail on that and actually give you lists of topics that are in each of these sections. And the question here is, why do we need to know this? Because we need to develop a framework for understanding what we do know and what we don't know about gene therapy for hemophilia so that we can make informed decisions and advocate as needed. We're all familiar in this room with hemophilia, and the principal characters that we'll be dealing with today will be factor VIII and factor IX, and the efforts to replace those genes in individuals who have hemophilia. We've seen a tremendous technology advancement over the past 60 years since plasma-derived clotting factors were invented in the late 1960s, based upon work that was done just prior to that to identify cryoprecipitate as the main active agent in plasma for being able to contain factor VIII and stop bleeding episodes. We had a disaster on our hands in the 1970s and 80s with the transmission of a whole series of viruses, the hepatitis viruses as well as HIV, that allowed us to move much faster toward recombinant clotting factors, as well as to improved viral inactivation technologies that have made plasma-derived clotting factors extremely safe today. About 20 years went by without a whole lot of activity, and then we had extended half-life products come onto the market, first in 2014. With not much room subsequent to that, we have had a series of investigational therapies emerge, one of which is approved, novel agents that are not clotting factors but can manage hemophilia A or hemophilia B. And then gene therapy has made its appearance, and that's what the focus of this session is about. But with this technology, each of these technology advancements, we also have been able to advance care for hemophilia. So we began with the plasma-derived concentrates that allowed us to do on-demand therapy to treat bleeds after they began. That was good, but turns out that didn't do much good for stopping any joint damage and joint arthritis progression. But then with the development of the recombinant factors and the safety of the newer plasma-derived factors, we were able to initiate prophylaxis. Some of that was started much earlier in Northern Europe, but eventually a number of companies undertook prophylaxis, and then that did begin to make a significant difference in progression of joint damage as well as general morbidity and mortality in individuals with hemophilia. And now we're moving into an era of 24/7 coverage. The absence of peaks and troughs and the ability to maintain a constant hemostatic level that can prevent bleeding episodes from occurring. And gene therapy certainly would be considered a part of that new armamentarium. So this is another way of looking at progress, and what we see here are the peaks and troughs on the left side of factor replacement, high peak, low trough, and then that changes a little bit with the extended half-life products, an increase in the duration of effect, and a decrease in the frequency of treatment, which is of benefit. And then as we move into the non-factor therapies, we can't really measure a factor level, but we can measure the effect and know that it's above a certain level to protect from bleeding. So that includes the anti-TFPI agents, fituzaran, the RNA inhibitor, as well as emicizumab, which is the only one of those that's now marketed for inhibitor patients. And now we move to gene therapy, where we can measure a factor level, and we can achieve hemostasis. And the question is, what level are we going to be interested in? And that's some of what we'll cover in the talk today. So this has been a time of very rapid change within the hemophilia community. Things were pretty static for a number of years, and suddenly, over the last 4 or 5 years, a plethora of new products, new companies have been involved, and now with gene therapy, we have a whole series of newer companies that are involved in attempting to better treat and potentially cure hemophilia. So the competition's very intense, and we really need to maintain the scientific integrity as all of these groups are competing for our attention with their messages. And this is probably as good an example of disruptive technology as anything in healthcare as we move toward curing genetic diseases rather than treating them. So I just thought I would show you this. This is a list of companies, by and large, started within the last 4 or 5 years doing gene therapy. A number of them are public already. Some are still private, and it gives you an appreciation for how intense this entire field is, not just for hemophilia, but for a whole variety of genetic and acquired diseases. Some of these companies, fortunately for us, are pursuing hemophilia, and also fortunately for us, the companies that aren't are developing technologies that can be applied to hemophilia. So all of this work is further advancing the field of gene therapy, and it means that a lot of money is going into this. As these companies get started, hundreds of millions of dollars are really ultimately going into each of these. And so that's good for advancing the science. We've had a number of new players come in, some of whom are older players now. So we've got with the anti-TFPIs, Novo, Nordisk, Pfizer, Bayer are all developing anti-TFPI monoclonal antibodies as a way of changing the balance between activators and inhibitors in the coagulation cascade. Alnylam has just moved their whole program over to Sanofi. They're using an RNAi, which is called fituzaran, also to affect the balance between positive and negative regulators. And then Genentech Roche with emicizumab, a bispecific antibody designed to bind factor 9 and factor 10, bring them together, and effectively replace factor 8. So that's the old at this point, although it's all quite new. Most of it's not even marketed yet. And now we have a whole host of companies, many of which are new, that are developing gene therapy listed here, such as Spark, Unicure, Sangamo, Dimension, BioVerativ is developing an alternative to some of the other companies for gene therapy, and BioMarin. And so this is all based upon a variety of different technologies, each doing something a little bit differently, all designed to get us to effective levels of factor 9 or factor 8 that could actually be curative. Let's make sure we're all on the same page and we know what we're referring to. So I'm going to go through a few basics in this talk. We all have trillions of cells in our body. And in those trillions of cells, we have 46 chromosomes in each of them, I hope. And on those 46 chromosomes, we have 20,000 genes or so. And those 20,000 genes dictate who we are, how we interact with our environment, and how we're able to function and grow and age. And so in those 20,000 genes, 2 of them are factor 8, factor 9, and then for individuals with hemophilia, of course, those have mutated so that they are dysfunctional or non-functional. And so that's what comprises our body. So all of those genes are inside of cells. So if we want to do anything to change those genes or to replace them, we've got to get new genetic material into the cell. And so how do we do that? Well, over the last 30 years, scientists have been trying just about everything and anything to see if they could push genes into cells. And so these abbreviations stand for lentiviruses, adeno-associated viruses, various polymers, liposomes, you name it, people have tried to get genes into cells. And by and large, despite thousands of papers that have been published, nothing much works except for viruses. Why do viruses work? Because they have spent 500 million years getting into vertebrate cells, and about 65 to 100 million years just getting into mammalian cells. And so they have perfected the ability to infect us. We, on the other hand, have been working toward defending ourselves against these viruses, so we'll come back to that problem in a few minutes. But what's been found over the past 45 years is that the genes can be removed from these viruses. The transgenes, or the genes that we want to replace, can be inserted into the viruses, and then the viruses are effective at getting across that cell membrane into the cell, getting the gene into the nucleus so that it can start to make the protein that we're interested in. So it's turned out that this is a very effective way to get genes into cells. In cartoon form, what actually happens, our gene of interest, in this case factor 8 or factor 9, is placed inside of a virus, and in this case I'm going to be referring to AAV, Adeno-associated virus, which has become the workhorse for being able to do this for many, many different diseases now. It's injected intravenously. Much of it goes to the liver, although some goes to a variety of other places as well, but it's designed to just express protein in the liver. So then once it gets into the cell, it makes its way to the nucleus, and then from the nucleus, RNA is made, protein is made, and the protein is secreted. Lots of animal experiments have been done to demonstrate the integrity and the robustness of this platform. About 2,300 human trials have been done using this virus. Most of them haven't been successful, but they have given us a good safety database, which also has been important. So I talked about entry into the cell and then protein gets made, but a lot of other things happen in between the time that virus penetrates the cell and protein actually comes out of the cell. And much of that is poorly understood. We know it can work, but we don't really understand everything about how it works. So what happens after the virus gets into the cell is that the coat of the virus needs to be removed so that the DNA that's inside of the virus can make its way into the nucleus. Exactly how that happens is not really clear, but the DNA does get into the nucleus, and in the nucleus it takes on a variety of different forms. Some of those forms result in destruction because we just don't have a lot of free DNA floating around. We've got mechanisms to destroy that. But some of it forms stable episomes that are resistant to destruction and can remain in the nucleus and take advantage of the nuclear machinery to be able to make RNA and then protein, the transcriptional activity shown in C. And then the protein goes through the usual pathway inside of the cell that all of our proteins go through as they get made, and then get secreted. We do have to worry about an immune response to the virus, and I'll come back to that a little bit later, but this whole process can induce an immune response. The reason for that is because this is a virus, and our cells are taught to react to anything foreign, such as a virus, that comes in. So the goal is to try to do this in a way to minimize any immune response. A lot of different viruses have been tried over the years, including different viruses for hemophilia. But AAV, as I mentioned, has become the workhorse because it's just worked in so many different experimental situations, whereas the other ones either haven't lasted or have caused so much toxicity that they're really not viral. They're really not viable. And then the holy grail here is non-viral delivery. Can we not use a virus and get the DNA into a cell? And try as we might, it just has not happened in an effective way in vivo. So that would be ideal because that would minimize any sort of an immune response. So we've settled on AAV because it works, it is taken up, it can produce protein, it persists for a long period of time, and it doesn't make as much of an immune response as some of these other viruses do. It's also, with the number of trials that have been going on over the past 15 plus years, it has a safety profile. So despite that many of these trials didn't necessarily work, they were for cancer, for a variety of other diseases, they have provided a safety profile for this virus. And manufacturing, while not at commercial scale at this point, because there hasn't been a need for it systemic use, is moving forward, and it is moving forward at rates that are greater than for some of these other viruses, which remain more problematic to make inside of a manufacturing facility. So to keep all of this in perspective, I've been talking about this in the context of gene therapy. By the way, all these slides will be available on the website for those of you interested. So we've talked about gene therapy. You've heard a lot of news about gene editing. Gene editing is really a more precise version of gene therapy. Instead of just putting the gene into a cell and having it go anywhere inside of that nucleus, gene editing can either replace the defective gene or it could put the new gene into a specific spot on the chromosome where we know it's going to be safe and will persist for the life of an individual. So that's almost ready for prime time, but not quite. There have been good experiments done in animals, including with hemophilia, and there is one clinical trial open at this point for factor IX that is utilizing gene editing, and I suspect that over the coming months and years, additional ones will come along, because I think it's a much more effective way of dealing with gene therapy than the kind of random way that we're all doing at this point. But it's not quite here. Another topic that has been in the popular news for years has been cell therapy, stem cell therapy, the generation of mature cells from stem cells. And that's also an area that's not quite ready for prime time. And the question in hemophilia is, if gene therapy can work, is it necessary to get much more complicated and do cell therapy? If cell therapy becomes more simple, then that may be something that becomes viable. And I'll just show one slide at the end on some recent work that's occurred in cell therapy in animals that is particularly exciting. Nonetheless, complexity increases as we go to the right, and so we'll confine our thinking at this point to simple gene therapy. So this is what the drug looks like. This is a construct. So this cartoon at the top is the gene. It's a promoter that will activate the gene, and this promoter is designed to only work in hepatocytes, cells of the liver. And so in that situation, even though the virus may go to other tissues, protein won't be expressed in those other tissues. The protein will only be expressed in the liver. The viral genes have been removed, but then they're added back separately so that the viral capsid, or the viral coat, can be made. And at the bottom, we get this intact AAV virion, or virus, and that's the drug. It's about 20 nanometers in diameter. and trillions and trillions of these are made. Quadrillions of these are made in manufacturing facilities now by GMP methods, good manufacturing practices, and then are administered clinically. So this has taken a long time to work out and to become much more efficient, but we're approaching the stage where large-scale manufacturing is already occurring. So where did this AAV come from? Well, it's been around for hundreds of millions of years, infecting prehistoric animals over that period of time. A primordial species that first infected mammals is called AAV Eve, perhaps appropriately enough. And this primordial species arose 25 to 47 million years ago in marsupials, and then gradually mutated and began to infect other mammalian species. So over the course of these last 25 plus million years ago, a variety of different variations of this virus have emerged, have evolved. And so many of them that we are most familiar with have evolved and infected primate species, including humans, and that's listed here at the top. A lot of different serotypes, as they're called, infect human and primate cells. Some of these are very close to identical to one another. Others are maybe 80% identical. So that means that, that there's a lot of cross-reactivity. If you make an antibody to defend yourself against one of these that you may have been infected with, that antibody may well cross-react with all or most of the other primate species. There have been other groups that have been identified. The problem with most of the other AAVs that have been identified in other animals is that they don't infect human cells. So while they may not be very similar and we may not have seen them, the reason we haven't seen them is because they can't infect us. There's one in particular, though, that was originally found in a human that was shown to be identical to, almost identical to a goat, and that's AAV5. And so in this case, this goat AAV mutated sufficiently to be able to infect human cells, and so is farther removed from the primate AAVs. And there will likely be many others. This is just the tip of the iceberg. I'm sure that the vast majority of AAVs out there have not yet been identified. And so there have been a lot of studies done to try to characterize these AAVs. People have looked at the different serotypes, which are shown on the left-hand side of the slide, and then they've looked at a variety of different tissues, usually in mice, to try to say that this particular AAV preferentially infects the liver or the muscle or the brain, and another one doesn't, and so we should use this one. Problem with all of that is that mice are not human, and so I think the whole field was sidetracked for actually many years by focusing on what worked best in the mice and then trying to move that to the human. And so at this point, most groups are actually doing these kinds of experiments in primates, which are much more closely related to human and much more predictive of what will occur in the human situation for targeting particular kinds of tissues. Something else that has been done by a variety of labs around the world is to look at the presence of neutralizing antibodies. Now, why do we have antibodies to AAV? We have antibodies because at some point in our lives we got infected with at least one of these, but they don't cause any disease. And so the infection has been inapparent, subclinical, but it still has been able to generate an antibody response that can persist for many, many years, decades. And so different labs have taken different reagents and different preparations of AAV and tried to figure out in 25 or 50 or 100 people what the prevalence is. None of that is able to be compared between labs because all the reagents are different, and so it's a mess in the field at this point. We don't know exactly what the true seroprevalence is, but we do know that it will vary geographically. So some areas of the world will have a higher antibody response to one particular serotype than another. And we know that it changes with age, so that the younger you are, the less chance you've been infected, and the greater your chance of not having an antibody titer. So what I've got on this slide, it's not exactly true. We could find 6 other papers that would show different numbers here, but the bottom line is that we have a fair amount of seropositivity, or evidence of previous infection in the population. That's a problem if we want to treat that population. So for many of these serotypes, half the population is positive. And at the moment, no one has really figured out how to circumvent that problem and get to that positive population to be able to treat them. So at the moment, they are excluded from clinical trials. That is going to be the case for a while until the field is able to determine how best to attack this problem. And it's a significant problem because it can eliminate up to half the population. What about that immune response? So the immune response is in 2 parts. I've already talked about the antibody response to AAV that occurs naturally. It also occurs if you administer the AAV vector. And we're administering such a high dose of the vector in these studies that the recipient makes a very high immune response, a very high antibody titer, antibody response. And so what that means is that the patient can't be retreated for the foreseeable future. This response lasts for a very long time. It also means, as I pointed out on the left-hand side of the slide, that these antibodies, if they're present, will block the AAV from getting to the target cell. So depending on the titer, it can neutralize all of the AAV that is injected. So that's a problem, and why individuals with pre-existing immunity have been excluded from most of the trials. Now, when it comes to viruses, we also make a T cell, a T lymphocyte response, and that T lymphocyte response is designed to destroy the cell that contains the virus. So our goal is to keep the virus out. We do that with antibodies, but if the virus makes it through and gets into the cell, it's going to display viral antigens on the surface of the cell, and we're going to recognize that as foreign, come in with these cytotoxic T lymphocytes and destroy that cell. And so that's a problem. It's a problem in the use of AAV, and in a number of studies, the cytotoxic T cells have been identified, and cells can get destroyed that contain the protein that we're trying to get expressed. We know that it's a dose-dependent effect, so the higher the dose, it appears that the more chance that these cytotoxic T cells will be generated. The lower the dose, the less that chance, but of course the lower the dose, then we have to deal with whether or not we're giving enough to get a good result too. So it's a balance, and what it really means is that there's essentially no therapeutic window for this. So if you think about any other drug, you have a therapeutic window where you can take this drug, and if you take a certain amount, you'll get into toxicity, but you've got a range. And that's actually how drugs get approved. You have to have a therapeutic window. If your therapeutic window is 0 and when you take it you get toxicity, that's a problem. Here, we don't have a therapeutic window. The toxicity is mild, and so that's probably not a concern, but it can compromise efficacy, and so ways have to be found to deal with the immune response. And I will talk more about that. So there's a lot of jargon out there. People throw a lot of terms around, and this is just one example of many that I'd like to just spend a minute on to help us understand what we need to do in order to educate ourselves about this kind of a technology. So AAV has been called for many, many years a non-integrating vector. What does that mean? That means when that term is used, it means it doesn't go into the chromosome and remain there in our chromosomes for the rest of our lives. It stays outside, and it makes the factor IX or factor VIII protein outside of the chromosome separately. And that's what the majority of it does. But most studies have shown somewhere between 0.01 to 0.1, maybe even 1% of the vector will integrate into the liver of animals and actually get into the chromosome. And when you say it like this, less than 0.01% vector integration, sounds like a good result. But what it really means is that if you're giving 4 trillion vector particles per kilogram, then a 100 kilogram person receives 400 trillion vector particles, and at 0.01%, that's 40 billion integrations that can go into the liver. So it's a lot when one looks at it that way. Plus, it can go into other organs as well. So it's really not a non-integrating vector. It's perhaps a minimally integrating vector, but there is some integration, and so we have to be aware of that from the point of view of long-term safety. All of these patients that have been tested in all of these other AAV trials suggest that this is not a problem, that no toxicity has been seen, but it's something that we need to take into account as trials are designed and as we look at long-term follow-up of patients as well. So I think our turning point really got published, at least, in December of 2017, just several months ago, when we had 2 papers in the New England Journal that described really effective therapy, gene therapy, for patients with both factor IX deficiency and factor VIII deficiency, hemophilia B and hemophilia A. And so I'll go into a little bit of the data from these papers as well, but it was the turning point for demonstrating that you really could use gene therapy to get therapeutic levels of factor VIII or factor IX that would be effective in preventing all bleeding in individuals with hemophilia. And then our own VP of Medical, Marika Vandenberg, wrote the editorial for one of these. So let's look at the trials, and I'll first go through the factor IX trials that have been done that are relevant to getting us to this point, and then I'll cover some of the factor VIII trials the same way. The first trial that really got us to where we are today was a trial done between Avogen, Bayer, and Children's Hospital of Philadelphia back about 15 years ago. That trial was partially successful for about 6 weeks. One of the final patients got 12% factor IX levels for 6 weeks, and then he lost it. And nobody knew where it went. And so I was involved in this. We spent 2 years and a lot of money to figure out that this patient made this cytotoxic immune response to the cells that contained the new factor IX gene. So that those cells were displaying some viral proteins on the surface. Our body recognizes that as foreign. We generated these cytotoxic cells, and they killed those cells. And when they killed those cells, they killed the exact cells that were making the factor IX protein. So not a good situation. And so everything shut down on that, and it wasn't until several years later that Amit Nathwani, Ted Tuddenham, and Andy Davidoff, both from University College London as well as St. Jude Medical Center in the United States, set up a new trial with factor IX and decided that as soon as they saw any mild liver inflammation, they would just give steroids, prednisone, and see if that would abort this cytotoxic T cell response. And in fact, it did. And so I'll show you a little data from their paper. But this was a really important paper because they provided the solution to this host defense against this viral vector. And so then others began doing work in the same area, replicating the work that Nathwani did. But it really wasn't until Spark came along that we saw any success. And along the same time, a variant of factor IX had been identified. It was first identified by Darrell Stafford at the University of North Carolina, Chapel Hill, back in 1998. If you change one amino acid at a particular spot in the factor IX molecule, the 338 spot, you can increase the activity of the factor IX by 7-fold. And so this was confirmed in real life when Valder Arruda from CHOP and his colleagues found two brothers, one of whom had a series of thrombotic events because he had this mutated factor IX, and he had 700% factor IX or something like that, very high amount of factor IX activity in his body. But the protein was normal, so it was just a much more active molecule. Well, that's perfect for gene therapy. If we can't get to a high enough level, as Nathwani and colleagues demonstrated, they could get to 2 to 6%. But if you can go 7-fold higher, then you can get into double-digit factor IX expression using the same amount of protein. And so that was the turning point for factor IX, and now most of the trials, if not all of the trials, are using this mutant of factor IX to enable factor IX gene therapy. So that's moving forward. This is the Nathwani paper. I don't know how well you can see this, but I'm just going to point out that we've got 10 patients that Nathwani and his group and the St. Jude group had tested. And in these patients, they looked for both elevations in liver enzymes, evidence of some inflammation in the liver, as well as factor IX expression. The factor IX expression is shown in the gold dots, the gold line, and the liver elevations, enzyme elevations, are shown in the green. And so what we can see here is that we're getting small levels of factor IX that are fairly constant over time, between 2 to 6% on average. But nonetheless, they were effective in controlling a lot of bleeding that some of the patients had. The little blue arrows at the top of each of these graphs are the times that these patients required factor IX replacement therapy for a bleeding episode. And so you could see some patients did quite well and had no need for exogenous factor IX, and some patients did not do well. And then the little purple bars are when these patients got prednisone because their liver enzymes elevated. And in most cases, what happened is that the prednisone rescued the factor IX and allowed the patient to continue to express some factor IX protein. So as I said, this was a really important paper and set the stage really for all the work that was to come ahead of it, or behind it, actually. So this is the SPARK study, and these are data that they released last summer, and they've continued to follow up and update this. But this essentially shows what I'd like to share with you. So over the course of a year, these are all individual patients. There's 10 patients, and they generated factor IX from 16 to 81%. So somewhere about an average of 30% factor IX activity after receiving the gene therapy. And so this was a remarkable result. We thought that Nathwani's result was terrific to get to 2 to 6%, decrease the use of factor IX, but in this case, getting to 30% was a game changer. And so what they were able to show is what you would predict in an individual who's got a factor IX level of 30% on average, that they had a large number of bleeds prior to going on therapy, which is shown on the left side of the left graph. And then as you put patients on therapy, 9 out of 10 of them had no bleeds at all. And it transferred to factor IX usage. They were using 100 infusions a year before going on therapy, and 9 out of the 10 patients used no factor IX therapy over the course of the following year after receiving treatment. So exactly the result you would want and what you would expect with factor IX gene therapy. All right, so what about factor VIII? There's less activity here because factor VIII has proved to be a very challenging molecule to work with for gene therapy, and has essentially produced negative results in the prior trials that were undertaken, but nobody had done an AAV trial at this point. And so the first AAV trial really was the BioMarin one that began a few years ago as a phase 1/2. And in that trial, they were able to achieve, as I'll show you in a moment, 100% factor VIII expression after a year. Subsequently, there are additional trials coming from other companies that are moving forward, some of which have started to generate data that looks like it will also be very effective in treating hemophilia A. So I think that adopting the principles from Nathwani, trying to sort out the use of steroids to make sure that we don't develop an immune response to the viral vector that can destroy the cells that make this factor VIII. All of those are important variables that are being pursued by each of these groups that is developing an AAV factor VIII. Each of the groups are doing something different. They're using a different serotype. They're using of AAV. They're using some different promoters to start the gene expression and different methods of producing the vector as well. This is the BioMarin data that they released, I think, late last year, and it shows through about 78 weeks. There's a shaded area there that shows the normal range of factor VIII. Normal range in all of us who have a normal factor VIII gene is 50 to 150%. And that's really the case for just about all of the clotting factors. So we've already got a wide variation intra-individually among all of us. And so what you can see here is that by the time we get to 16 weeks or so, we're in the normal range and actually around 100%, and that remains the case for the duration of this study. And so what we can see here is that AAV5 delivering a B domain deleted factor VIII gene, which is what everybody is using for AAV now, will effectively replace the factor VIII activity that is missing in individuals with severe factor VIII deficiency. And like the SPARK study with factor IX, if we look at the bleeding rate before and after gene therapy, it's about 16 in the patients before they received their gene therapy in the year before. And afterward, after the expression of factor VIII is at least 5%, they have no bleeding episodes. That transfers to the amount of factor VIII that's used. They took on average 138 injections the year previous to receiving the gene therapy, and they had 0 injections afterward. So we've had a long road, a very long road in hemophilia. I actually gave my first talk on gene therapy for hemophilia in 1985. Yeah, that was a long time ago. But by 1999, we had a few companies go into the clinic for gene therapy, and they set the stage, they paved the way. None of it worked at that time, but it enabled a number of observations to be made. This is an iterative kind of process. And so all of the work that was done set the stage for the present and the variety of companies that are pursuing variations on a theme, all using AAV at this point, but different types of AAV and different constructs of the factor VIII or the factor IX gene. So we've got a lot of activity. These are just the people in the clinic, the groups that are in the clinic. There's a whole bunch of people that are still doing preclinical work that may or may not get into the clinic somewhere down the road. And so some of the most promising work actually moves to the future box over here, where we'll see the next generation of gene therapies come along. BioVeritiv, for instance, is working on lentivirus as an alternative to AAV. It has advantages and disadvantages compared to AAV, but nonetheless, it has been approved for use in severe combined immune deficiency disease in Europe and a couple of other diseases as well. And then there's gene editing, and a number of gene editing companies are developing gene editing therapies for hemophilia also. So I think we'll continue to see improvements in what we've got today come along that are in preclinical testing, and the best improvements will rise past everything else and move forward and get developed because they'll look like they will be more important and more useful. So this is a very familiar graph to probably everybody in this room, and I want to use it to just point out the question, how much factor do we need? That's the question at hand. And so on the basis of this graph that was published about seven years ago now, somewhere around 12 to 15% looks like the minimum to prevent any joint bleeding. We know that in individuals that have really severe target joints, you probably need a little more than that sometimes, and for significant trauma, you probably need a little more, but that's a good basis. We also know that at 3%, we only get 1 to 2 joint bleeds a year, but that's really an unacceptable number if we're thinking about gene therapy. If you think about the risk and benefit of gene therapy, you really need to get to a point where you have a large improvement over recombinant protein replacement, which also gives a few bleeds a year, even with the best prophylaxis regimens. And so the question that we're left with is what dose of factor VIII or factor IX should we have, and should we attempt to get to normal levels, 50 to 100 or 50 to 150%, which is the normal range in the population. So that's an unanswered question at this point, but one that will get answered through the clinical trials. So now I'd like to go through a framework for thinking about all of these complexities of gene therapy and all of the unanswered questions that are with us. And a good framework is something that has been around for the better part of 50 or 60 years, but it actually got popularized by former U.S. Defense Secretary Donald Rumsfeld, and has been a useful framework for any series of complex problems. So we'll go through a little bit of this. We have a 4-square box, and so what we have, if we look at the upper left and then move down to the bottom, is we have the known knowns, and that is what we know that we know. So there's a lot about this gene therapy that we know about, and we can rest assured that we've got some good data that helps us to understand, at least up to this point, what's happening. We also have the known unknowns, and so those are, which are shown on the top right-hand corner. That's what we know that we don't know. So we know that these antibodies are a problem, but we really don't know how to solve it. That's a good example of what we know we don't know. How are we going to solve that problem? How are we going to solve the immune response problem? So that's a big category, and that's a category we'll spend more of our time on. So then if we move to the bottom left, it's the unknown knowns, and these are the things that we forgot we know. And it may sound funny, but there's plenty that we just take for granted, and then if an adverse event happens in a clinical trial, we say, oh, we should have thought of that. Why didn't we? That happens a lot. So we forget that we know things that we could have predicted, but we ignore. And then we have the unknown unknowns, and that's what we don't know. And whenever you're dealing with a technology that is as foreign as this one, there are going to be these unknown unknowns, things that are going to come up that we don't know about, and we can't even predict. And so that's the nature of science, that's the nature of medicine, and that's the nature of drug development. So we have to be attuned to look for those as they may emerge. So let's focus on the things we can address and the topics that we know we don't know about. So what are those? Well, I've already mentioned we've got some integration into our genomes of these AAV vectors. What are the consequences of that? So far, none, but what about long term, and how do we need to monitor patients for any potential consequences? This mild hepatic or liver inflammation, how do we best manage it? Is prednisone the best way of doing it? Should we give the prednisone prophylactically? Should we give it whenever these liver enzymes start to arise? Groups are doing it both ways. We don't know the answer to that. Where is the vector going in the body? We've got an idea from animals where it's going, and a lot of it goes to the liver, but the rest of it goes to a variety of other tissues. What's the effect of that? So far, it doesn't appear that there's any negative effect, but it's an unknown question, too. We have variable protein production. So whether you look at Nathwani's data from 2011, where he had variations up to 10%, or you look at the Spark data, 16 to 81%, or the BioMarin data, where it went to supernormal levels. Why is it that individual patients are responding to the same dose of vector in different ways? No idea. So another question that needs to be answered. What about this pre-existing immunity? To me, it seems like that's a really big problem if with some of these AAV serotypes, half the population can't take advantage of the gene therapy. So how can we circumvent that? A number of ideas have come out, and I think some of those will be clinically tested, and so we'll begin to know how we may be able to address this pre-immunity and whether or not it can be addressed. Big question, how long will it last? What's the duration? Well, we don't know. What we do know is that from Nathwani's study, it's lasted a number of years at these very low levels. We also know from dogs that were done back in the early 2000s that it lasted for the lifetime of the dogs, which was 10, 12, 13 years. In the recent human trials, we know that we can go out a couple of years and continue to see levels. And so it looks like it's lasting for a while, but will it last consistently for 5 years at therapeutic levels, 10 years, or longer? We don't know. And that's the sort of thing that can't be tested in mice because they only live for 2 years. How much factor is enough? That's what we covered on the previous slide. Is 15% enough, or do we need 50 or 100% in order to adequately be protected from any bleeding? Can this gene be readministered? Well, so I think strategies need to be developed there as well. And I know there are a number of initiatives that are being considered, and so we'll see how that develops, but it's still an unknown question at this point. What about children? So children have livers that grow very rapidly at a young age, and remember I told you this viral vector doesn't really, most of it doesn't get into the chromosomes. It stays extra chromosomal. And so as hepatocytes divide, the vector can be lost. The DNA can be lost. And so it's not clear that young children can be treated. It's also not clear at what age treatment can occur, what age treatment wouldn't be effective. We know from some animal work that very, very young animals will kick that vector out, will kick the DNA out within weeks. And so it's unlikely within the first couple of years that it's going to be effective, but we don't know if at age 5 or 12 or 15 it would be as effective as it is in adults. How about HCV? A number of the population either have HCV or hopefully have been cured of it by now, but may have some damage in their livers. And so we don't know what the effect is there. The trials are open to patients who've previously had HCV but have been cured or have naturally cleared it, but they also need to have their livers checked for damage. And so if it's too damaged, then they're excluded from the study just because of wanting to protect that liver, given that the AAV is going into the liver and causing a little bit of inflammation anyway. And then the manufacturing, it has not been scaled up for commercialization yet, and so that's an unknown question as well. Can we get good, robust manufacturing at a cost-effective, in a cost-effective way to allow more widespread use of the AAV gene therapy? So we've been very concerned about primary endpoints, and think that the factor 8 or factor 9 level ought to be a primary endpoint. The EMA has agreed, the FDA has not agreed with that, and think that annualized bleeding rate is a better endpoint. But when you're at these levels and you have essentially no bleeding, it's not clear that that's an effective primary endpoint that can discriminate adequately. In any event, whether this gets sorted out or not, all of these are endpoints and will be evaluated in these clinical studies. Work that has been spearheaded by Alfonso Iorio and Mark Skinner is looking at standardizing the kinds of outcomes that would be measured in phase 3 clinical trials. So they're just getting started now. And so now is the time to try to get some level of standardization so that we can make comparisons between trials rather than have different trials look at different endpoints. And so this group brought together people from a variety of backgrounds ranging from patients to payers and everyone in between to reach a consensus on the best endpoints to use for gene therapy clinical trials. Some of these you would expect to be the core outcomes, and some aren't things that we've thought about for the protein replacement trials. So frequency of bleeds, factor activity level, those are important for the reasons that I've shown you when I showed you the results from SPARK and BioMarin. Duration of expression will be an important one. And chronic pain. So with high levels of factor 8 or factor 9 circulating, all of these microbleeds will stop occurring. And so anything that's a mild target joint to a severe target joint will quiet down. So what's the effect of that on the pain, on daily pain that the patient experiences? And then utilization of the healthcare system. Hemophilia is a very expensive disease. How will gene therapy affect that? And can a cost-effective solution that makes everyone happy, from the patients to the payers, be identified? One of the more interesting ones that come out is mental health of the patient. So after you've received this gene therapy and you're no longer dependent upon factor 8 or factor 9, how do you feel? What's it like to go from thinking about your hemophilia every minute of every day? You take a step, you feel a little pain in your ankle, you say to yourself, am I bleeding, or is it just my arthritis? So that happens to an individual with hemophilia every minute of every waking day. That goes away. If you have a little pain after if you're at 50%, you're not going to be thinking that you're bleeding. And so how do we measure that? That's really what the question is, and that's what the next phase of the core heme group is set to do, is to try to define measurements that can capture this feeling of living with a chronic disease to not living with a chronic disease any longer. So who's eligible for gene therapy? I've alluded to this. It's pretty restrictive at this point. Adults, children later, in part because we don't know how long it'll last in children, and in part just because of the risk-benefit ratio. Let's make sure it's safe in adults before giving it to kids who cannot offer consent. Patients with severe hemophilia, so 1% for the factor 8, I think is in most of the trials, and then up to 2% for factor 9. And so it's important to get started with the patients that would benefit the most. I already mentioned HCV and in that exclusion. No pre-existing antibodies, I've already mentioned too, to the AAV serotype for the therapy. Patients that have never had an inhibitor, and the reason for that is that if an inhibitor should show up in one of these gene therapy trials, you'd want to know that that patient never had an inhibitor before, and this inhibitor may be due to the gene therapy. If you take patients that have previously had inhibitors, then you'll never know the answer to that. Did it just reappear, or did it reappear because of the gene therapy? So the trials need to be clean on that. Although I think it will be very important and very interesting to run a clinical study on inhibitor patients with gene therapy for factor VIII in particular, and see if that can tolerize the patient. And I know that different groups are thinking about that as well. These are really intensive clinical trials, sometimes twice-a-week testing, and so as a patient that participates, you need to make a commitment for a long period of time to be involved in this. And then you also need to live in a country where this investigational therapy can be commercialized, which limits it considerably as well. So as more experience is gained, I think that some of these criteria will be loosened up, but for now, that's the case. So this is really exciting. Since 2015, we've seen therapeutic levels of factor IX and factor VIII be achieved in a small number of patients, and those levels have relieved them of their dependence on exogenous replacement therapy. We need at the same time to continue to address the questions that I've raised, plus many more questions that I haven't thought about. And then it's useful to point out that in drug development, when research hands the drug off to development to go put this into the clinic, research tries to scale back so that they can move on to the next project. In a case like this, you really need to continue to do research. We just have far too many questions to have research stop. Research needs to continue. It needs to continue in animals to further support the clinical work, and then intensively, it needs to occur in the patients. And so we can't forget that this is still an early technology that requires much more information. For us, education is critical. This is complicated stuff, and we need to learn as much about it as we can. We need to ask the questions of our healthcare providers, and our healthcare providers need to ask questions of the experts who can help them to understand the technologies that are behind this technology. So what's next? Well, gene editing, I mentioned before. And so it could not only turn Chihuahuas into Great Danes, but it could turn Great Danes into Chihuahuas too. Unfortunately, nobody knows what those 3 genes are that would do that. But if they do discover that, you can be pretty sure somebody's going to try to commercialize that. So that's what gene editing, the power of gene editing, and it can be used for much more serious things than this. We can already clone dogs, so I think the future is pretty wide open. But in terms of gene therapy, it's really going to represent the next stage of knowing exactly where the gene is going, what it's doing, and how it can best be utilized. And then the other technology that's even more difficult that I mentioned before is cell therapy. And with cell therapy comes the complexity of working with cells, usually outside of the body, and then needing to get them back into the body. But I just want to highlight this paper that was published just a couple of weeks ago by a well-known lab, Inder Verma's lab at the Salk Institute in San Diego. And so what they did is that they took peripheral blood from patients, 2 patients with factor IX deficiency, and they purified out the white cells, and from those white cells, they were able to add some factors to reprogram them and basically turn them into liver cells. In the process of doing that, they corrected the patient's factor IX gene, and they put in a new factor IX gene so that the old gene was kicked out, the new normal gene was put in, and then they grew them up in a large volume, put them into mice, and then reconstituted the liver of those mice with the hepatocyte cells that contain the normal factor IX. And as you might expect, since the paper got published, they were successful. They got blood clotting, they had factor IX levels, and they got functional disease correction. But as I said at the beginning, this is just much more complicated than gene therapy or even gene editing in gene therapy. And so it's not clear what role it's going to have in the future, but it's a beautiful proof of principle that can show what you might be able to do, starting off with peripheral blood cells and turning them into liver cells. So this graph is a typical performance versus time graph that all industry uses to look at their processes, and I've turned it into the future of hemophilia care. And so as we look over time and increases in performance, we have our conventional clotting factors, the bypass agents for inhibitors, which don't work as well as the conventional clotting factors. We've moved to the extended half-life products. Non-factor replacements with higher trough give us increased performance. And then something like gene therapy, I think the question for us is this the disruptive technology that will cut through all of these other agents and be the technology that disrupts this entire field? And that's what these clinical trials will answer. So I would be remiss if I didn't remind us of the fact that most everything that was on that last graph applied to 15% of the world, the 15% of the world that has access to all of these therapies, and it does not apply to the 85% of the world that doesn't. So we have a huge disparity here. 15% of the world uses the majority of the product, 85% has very little product. What's wrong with this picture? And so I hope that as we develop gene therapy, we figure out how to fix this large imbalance that's causing so much misery, death, and destruction in the rest of the world. I'll leave you with a quote from our new FDA commissioner, who actually seems like he's pretty good, surprisingly enough. Here's what he said. He's been on target in really moving drugs through and getting drugs to patients. So he said, "I believe gene therapy will eventually become a mainstay in treating and maybe curing many of our most devastating and intractable illnesses." With that, this is my summary. Lots of new letters, lots of new words to learn. It's a foreign language, but we need to learn it. And thank you.